Hello, my name is Max Wintermark. I'm the Chief of Neuroradiology at Stanford, and today we're going to review together the typical imaging associated with intracranial hemorrhages. On this first slide, you can see 15 different head CTs, and each of them basically demonstrate one particular type of intracranial hemorrhage. You can see that the pattern is different, and that's going to be the key as we move forward through each of these cases. We're going to see that with a little bit of clinical history combined with the appearance and the distribution of the intracranial hemorrhage. It's usually possible to assign a relatively specific cause to the intracranial hemorrhage, and that's the exercise that we're going to go through. We're going to start with the most common intracranial hemorrhages and work our way through to the less common ones. Since we're going to start with the most common ones, we're going to start with head trauma because that's the number one cause of intracranial hemorrhage. And we're going to see that there can be different types of intracranial hemorrhage in the setting of head trauma. And the first one that you can see on those images is an epidural hematoma. There are different features that makes this typical epidural hematoma. So the first feature is that you can see that there is this biconvex shape to the hematoma. So that's very typical of an epidural. Another feature that is typical also is the association with a fracture on the side of the hematoma, because typically the epidural hematomas develop at the site of the coup, which is where we see it here, underlying the fracture. We can see also that epidural hematoma basically can extend along or across dural attachments. We'll see it's different when we come to subdralymatomas in a bit. On the other hand, epidural hematomas cannot cross sutures, and typically, for instance, this hematoma here is contained by the coronal suture. Something that we don't see on imaging, but that we know, is that typically epidural hematomas are of arterial origin, so they typically tend to grow relatively fast. From a clinical perspective, there's something called the lucid interval, so the patient has the trauma, is doing well for a while, and then after that, their clinical condition deteriorates quite quickly. So that's the typical clinical presentation. It doesn't always present that way, but that's typically the textbook presentation of those epidural hematomas. And we know that epidural hematomas usually have a good outcome because they tend to happen in young patients with a normal underlying brain. And so if they are diagnosed in a timely fashion and taken care of in a timely fashion, usually the patient has a favorable outcome. And we're going to see that differs from the next type of intracranial hemorrhage that we will be looking at. And so we're getting to that next type, and that next type is a subdralymatoma. So part of the exercise is to look at the features that allow us to differentiate an epidural from a subdralymatoma. So as you can see here, first, the shape of a subdralymatoma is different. It typically has this crescentic shape as opposed to the biconvex shape that we saw for epidural hematoma. So that's the first thing. Second thing, subdralymatoma can occur in the absence of any kind of fracture, and they typically tend to happen at the side of the contracus. So you are going to see the skin contusion on the contralateral side to the subdural hematoma. That's also different from the epidural hematomas that happen at the site of the coup underlying the fracture. We will come back a little bit to that fact later, but the reason why subdural hematomas typically develop in the absence of fracture is because they result from the tearing of bridging veins, and that typically happens because the brain is relatively small compared to the skull cavity, and that typically happens in very young children or in older patients when there is some degree of brain atrophy. And as a result, the brain can relatively move within the skull cavity, and that's the way that in the setting of a trauma, those bridging veins get torn. And so, as we just mentioned, typically a subdralymatoma has a venous origin. Initially, because it's venous, one might think that the prognosis is going to be better than the epidralymatoma, but actually it's exactly the opposite. And the reason is, as I mentioned, typically subdralymatomas tend to happen in older patients with an abnormal underlying brain, and those patients are going to fare less well when they have a trauma. And so that's why typically subdralymatomas are actually associated with a worse outcome compared to the patients with an epidralymatoma. Another difference between epidural and subdralymatomas is that subdralymatoma can cross sutures. It's clearly evident here with respect to that coronal suture. On the other hand, the subdralymatoma cannot cross a dural attachment, cannot extend from the left to the right hemisphere, but instead is going to extend along the dura, along the falx, or here in a different patient, along the tentorium. One thing that I didn't mention earlier for epidural and subdralymatoma, one thing that they have in common in some ways, that one thing that's always important to comment on when you prepare your report for these patients is to comment on the amount of mass effect, because that's something independently of the type of extraaxial hematoma that's going to influence patient management. And you can see that in this first patient, for instance, there's quite a lot of midline shift, perhaps a little bit of beginning of subfalcine herniation, and there's probably also entrapment of the right lateral ventricle. So those are important things to report, because again, they are going to have an impact on the patient's management. Another thing that I also wanted to remind all of you is that there's a typical density associated with the age of the hematomas, typically the subdralymatomas, because an epidralymatoma, as we say, typically is going to be taken care of very quickly, and so we'll never have a chance to become subacute or chronic. On the other hand, subdralymatomas can become subacute and chronic, and typically, so the density of the blood starts by being hyperdense, and as time elapses, it becomes first isodense in the subacute period, and finally hypodense in the chronic period. Now, there's one exception to that general rule that is illustrated here. Sometimes in the very hyperacute period, you can have some dark areas within the regular hyperdense hematoma, and you shouldn't interpret that as being acute and subacute. Rather, you should remember that swirl sign, and remember that those areas highlighted here by this black arrow basically can represent areas of acute bleeding, and that tells you that this extraaxial hematoma is actively bleeding, that it's very likely to increase in size. And you can see that in that case there was very significant midline shift to the left with subfalcine herniation, entrapment of the ventricle. A few slides lower, probably we would see also some right ankle herniation, and again, because of the swirl sign, we know that this hematoma is going to grow, that mass effect is going to become even worse, and so something needs to be done immediately. And as a neuroradiologist, our job is to immediately call the neurosurgeon so that they can manage that patient appropriately, which most likely is going to bring the patient to the OR for evacuating that extraaxial hematoma. So those were the first two types of hematoma in the setting of head injury, epidural and subdural hematomas. Here we see a parenchymal hematoma, and here my point was to remember that when you have a parenchymal hematoma, sometimes it can also be an extraaxial hematoma, and it's adjacent to the falx, so adjacent to the tentorium. You should always remember that it may not just be a hematoma on its own, but that there might be an underlying traumatic injury, for instance, a traumatic pseudoaneurysm. And here you can see actually that there's also a little bit of subarachnoid hemorrhage in the sylvian fissures. There's also some intraventricular blood. And so all those little clues should raise your concern about the possibility of an underlying traumatic pseudoaneurysm, and should prompt you to recommend a CT angiogram. It was done in this patient, and you can see that the patient had indeed developed a traumatic pseudoaneurysm close to the ACOM and where the A2 segment of the anterior cerebral arteries are. It typically again happens close to the falx or close to the tentorium, because during the trauma mechanism, those arteries get sheared basically against that dural folding, and that's the way that the traumatic pseudoaneurysm develop. Now we see here another pattern of intracranial hemorrhage in the setting of trauma, and it's diffuse axonal injury. So you get those petechial hemorrhages. We see them here at the gray-white matter junction, as well as in the dorsolateral midbrain. This case is a relatively rare case because typically in a patient with diffuse axonal injury, they may have those lesions, but typically we do not see them on a plain head CT. But sometimes we do, like in this patient. Typically when we see some, like in this patient, it's just the tip of the iceberg, and there are actually way many more that we don't see. The typical technique of choice to detect those microbleeds that happen in the setting of diffuse axonal injury or traumatic axonal injury, it's MRI with either gradient echo or susceptibility weighted imaging. And again, you see those microbleeds that are going to be seen at the gray-white matter junction, in the dorsolateral midbrain, and you can also get them in the corpus callosum. The reason why they happen in those locations is because at the gray-white matter junction, there's a different density between the gray and the white matter. And so when you have a deceleration or rotational mechanism, basically there can be some differential motion of the gray and the white matter. And that's why the axons get torn at the junction between the two of them. And in the dorsolateral midbrain and the corpus callosum, it's more that there are some white matter fibers that are very tightly packed. And so they are more susceptible to those rotational and deceleration mechanisms. So those are the areas to look for those microbleeds. Sometimes, of course, there is some non-hemorrhagic diffuse axonal injury that you can capture on diffusion, but that goes beyond the topic of today's talk, which is again dedicated to intracranial hemorrhages. So we kind of covered here head trauma. I didn't show you hemorrhagic contusions. I could have done that too, but I think we have a good overview. Now let's move to a different entity, and actually we're going to kind of discuss two entities a little bit side by side. For all those trauma examples, there is this clinical history of trauma. So now we're going to shift gear a little bit. And for the next two entities, there are a couple of factors. There can be some overlap, but there are a couple of factors that allow us to differentiate them. So here in that first case, we have a relatively young patient, 40, 50. So that's usually kind of a clue. We can notice that we have intraparenchymal hemorrhage affecting the basal ganglia. There's also probably a little bit of rupture in the choroid plexus. And then we notice that there may be a little bit of white matter disease, but not a huge amount of it. And so that typically, that pattern, basal ganglia hemorrhage, it could be also lumbar hemorrhage in a relatively young patient, should raise a concern for arterial hypertension. And that's what was the case for this patient. Now I would like to differentiate that scenario from the next one I'm going to show you. So this time we're not dealing with a 40, 50-year-old patient. We're dealing with a patient who is much older, for instance, in their 80s. We again have a lumbar hemorrhage, but here the thing that is striking is that we have a lot of chronic ischemic small vessel disease. Unfortunately, this patient passed away, and you can see that in addition, on the autopsy specimen, you can see that in addition to that large area of intraparenchymal hemorrhage, you also have multiple parenchymal microbleeds that are distributed throughout the brain tissue. And this scenario, an older patient, a lot of white matter disease, a lumbar hemorrhage, perhaps some additional microbleeds, should raise the concern about amyloid angiopathy. And I just wanted to show you that sometimes you can capture those patients before they develop an intraparenchymal hemorrhage, and you're just going to see those microhemorrhages. Again, we have seen those microhemorrhages for trauma. Actually, microhemorrhages can also happen in patients who have chronic arterial hypertension, and they can happen also in patients with amyloid angiopathy. So again, the scenario, trauma versus no trauma, the age of the patient help you a little bit. And the distribution also of those microbleeds can give you a clue. We have seen that in the setting of trauma, of diffuse axonal injury, it's the gray-white matter junction, the corpus callosum, the dorsolateral midbrain. In the setting of chronic arterial hypertension, it's usually the basal ganglia. In the setting of amyloid angiopathy, it can be a little bit everywhere, including in the hemispheres, the cerebellum. And those are going to be the clue to help us be guided in, towards one diagnosis as opposed to the other. So we've discussed trauma, we have discussed arterial hypertension, we have discussed amyloid angiopathy. Now let's get to our next pattern. So in this setting, we can see that we have some intraventricular hemorrhage. There's also probably some, so there's some blood in the lateral ventricle, probably also in the third ventricle and the aqueduct of Sylvius. There's also probably a little bit of subarachnoid hemorrhage. So when the predominance of the blood is in the subarachnoid space, and also in the ventricular system, vascular malformations should come to mind. So aneurysm, arteriovenous malformation. Again, a CTA should be obtained as the next step following the non-contrast head CT. And we can see that in that case, in this patient, we had basically an arteriovenous malformation with a nidus that ruptured in the ventricle and the subarachnoid space, explaining the pattern of hemorrhage that we saw in this patient. So another very important cause of intracranial hemorrhages are all those vascular malformations. I want to show you cases of an aneurysm. So you can see here that very diffuse subarachnoid hemorrhage in the interhemispheric fissure, in the bilateral sylvian fissures, also involving the basilar cistern. And you can see that in this patient, that pattern was caused not by an arteriovenous malformation, but quite large supraclinoid internal carotid artery aneurysm on the right side. And here, because it's a 3D view and we look for the top, it shows up on our other side, but it's still the right side of the patient. Before we move to the next type of intracranial hemorrhage, I wanted to discuss two things. So the first thing I wanted to discuss with you is that there is a specific type, a special subtype of subarachnoid hemorrhage that is called Permacent cephalic venous subarachnoid hemorrhage. So what is this entity? So in terms of intracranial hemorrhage pattern, you have a relatively small amount of subarachnoid hemorrhage, and typically, as the name says, Permacent cephalic, it tends to be located in the basilar cistern. And that's a case where you are going to get a CT angiogram to try to detect the underlying vascular malformation. The CT angiogram is going to come back negative. The patient is going to undergo one or perhaps sometimes even two conventional angiogram to detect again an underlying vascular malformation, but you still don't find that vascular malformation. And so at the end, it's just assumed that it was not caused by an arterial venous malformation or an aneurysm, but instead just by the rupture of a vein. And so that explains the name Venous. Typically, those patients have a very good outcome. They do not develop hydrocephalus or vasospasm like patients who have more significant subarachnoid hemorrhage as a result of a ruptured aneurysm or arteriovenous malformation. If you look very carefully at the CT angiogram in these patients with Permacent cephalic venous subarachnoid hemorrhage, and especially if the CT angiogram is a little bit venous, not infrequently you can detect some abnormalities in the venous drainage. For instance, in this patient, you can see that the internal cerebral vein, instead of draining in the vein of Galen, drains directly into the straight sinus. And that kind of vascular abnormality, venous abnormality is quite frequent in those patients with Permacent cephalic venous subarachnoid hemorrhage, and they probably contribute to the pathogenesis of that condition. Before we move on, I also want to discuss with you the different type of cerebral vascular malformation. So we discussed some about aneurysm and arteriovenous malformation. I wanted to mention two other types, so cavernomas and DVAs, and I mentioned them together because they tend to be associated with each other. So the DVA, the developmental venous anomaly, is the abnormal draining vein, draining normal brain tissue. So typically we don't do anything for DVAs, but sometimes as a complication of those DVAs, patients can develop cavernoma, which is this kind of pocket of blood that can appear as hyperdense. It also tends to calcify. I'm going to show you a couple of examples later. And typically DVAs, again, are just abnormalities, but they don't have consequences. Cavernomas, on the other hand, can rupture and cause intracranial hemorrhages. Typically, the risk of rupture is 2 to 3% a year. Here's the MRI companion of that case that I showed you. Again, this typical caput medusae appearance of the DVA, and otherwise that typical appearance of the cavernoma, very well seen on the GRE or the SWI images. And sometimes some patients can have familial cavernomatosis. They're going to have multiple cavernomas. And when it's this familial form, typically cavernomas are not associated with DVAs. And finally, here in a patient with familial cavernomatosis, I just wanted to show you the fact that those cavernomas can develop calcification, well seen on CTs, and this typical popcorn appearance of those cavernoma calcifications. The last type of vascular malformation that I wanted to report today are capillary telongectasias. So capillary telongectasias, again, are in some way malformations, and again they never bleed, they never cause any kind of symptoms, and they should as a result not be touched. They are do not touch lesions. They typically enhance on the post-contrast images. We're going to see in a minute that they have some susceptibility on the gradient echo, the SWI images. But one typical characteristic is there is no edema associated with them on the T2 or the FLAIR images. Here again, same type of findings. So this abnormal enhancement, the susceptibility on the gradient echo, the susceptibility weighted imaging, but no abnormal FLAIR or T2 signal. Again, they have typical location. The pons is a very good location for capillary telongectasia. And again, I think that here the clinical scenario is often a patient will come for something else because they have a primary tumor. You are asked to do a brain MRI to detect potential metastasis. And when you see that enhancement, you might think about a hemorrhagic metastasis, but what your clue should be, say there's no edema, abnormal T2 signal like you typically have for a metastasis, and that should tell you that this is not a metastatic lesion that's going to change the staging of the patient. Instead, it's just a benign vascular malformation, a capillary telongectasia. So important entity to remember. So let's come back to our intracranial hemorrhages. So we discussed again head trauma, we saw arterial hypertension, amyloid angiopathy. We discussed in depth all those vascular malformation. Now we're getting into the patterns that are a little less frequent. And here you can see in this patient, basically you can see that there are those patchy hemorrhages. So we don't have a big blob of intracranial hemorrhage like we have seen in our previous patients, for instance, with the arterial hypertension or the amyloid angiopathy. The other thing here that is quite striking is that there is some interspersed edema in between those patchy foci of intracranial hemorrhages. So one thing that you might think of would be the hemorrhagic transformation of an ischemic stroke, but what doesn't work that well here is the distribution. It doesn't really conform to a vascular territory, or at least I should say an arterial territory. And so here, the entity that you should think of is a venous infarct. That's the typical appearance of a venous infarct. And when you think of venous infarct, you also have to think of venous thrombosis and venous sinus thrombosis. And sometimes you can, so we're going to see different examples. So here's an example where you see the cortical vein thrombosis with these venous infarct surrounding it. Not a lot of hemorrhage, but perhaps a little bit of it. Here we have, when you look for venous sinus thrombosis, you can do it using a CT venogram. You can do it using an MR venogram. Sometimes also just plain 3D T1 post-contrast images do also a great job at detecting those venous sinus thrombosis. And you can see here that the superior sagittal sinus fills up, perhaps a small arachnoid granulation, and then you have a big filling defect. And on the images perpendicular to the superior sagittal sinus, you can see this empty delta sign that is quite characteristic of a sinus thrombosis. And again, here's the superior sagittal sinus, but it could be any of the sinuses. And so here, let me give you an example involving a different sinus. So here you can see that you have this hyperdense transverse sinus. You can see again that filling defect. In that case, it was in a pediatric patient. It was caused by an automastoiditis on the same side. And here are the MR images. So you can see the filling defect on the MR venogram. The post-contrast images, you always have to look at them with a little bit of caution. You have to also look at the pre-GAD T1 weighted images, because in that case you have a lot of T1 shortening. So this is not enhancement. The sinus is not enhancing, it's thrombosed. But you just see the T1 shortening of the clot in the right transverse sinus. And again, all those findings of automastoiditis with all these abnormal signal and enhancement in the right middle ear and the right mastoid hair cells. So here we covered quite a lot. Brain tumors, of course, any kind of intracranial hemorrhage can be the result of some kind of brain tumor, but usually it's kind of an exclusion process, and you go through those other conditions that we discussed earlier, and then when you have excluded them, then you are left with a brain tumor. The important thing for brain tumor to remember is, of course, a large brain tumor can bleed, and you're going to see the brain tumor and the bleed within it. But sometimes what can happen is you have an intracranial hemorrhage, you don't see clearly an underlying mass, you have kind of ruled out those other entities that we discussed previously, and you cannot find any of the other. And so then you have just to remember that it could be a brain tumor, and it's very possible that in the acute phase of the hemorrhage, because of the mass effect of the hemorrhage, the underlying tumor may be obscured. And so what is important in that setting is to obtain some relatively short-term follow-up imaging after a couple of weeks once the hematoma has resorbed, so that you have a chance to detect in a timely manner that underlying brain tumor. And finally, some patients received anticoagulation or antiplatelet medication, and those patients are more at risk of developing any types of the bleedings, that the intracranial hemorrhages that we discussed today. But for instance, this patient developed a subdralymatoma, and sometimes that can happen really with very minor trauma, but again, they are predisposed because of the medication that they are taking chronically. We're going to finish our presentation. I wanted to show you that not everything that is bright on CT is necessarily an intracranial hemorrhage, and that's something that is very important to remember. There are a couple of mimicking conditions. So you have this patient, and if you look at this patient and at this CT scan too quickly, you might falsely conclude that you are dealing with diffuse subarachnoid hemorrhage. But if you look at this case a little bit more carefully, you can see that it's very hard to detect to differentiate the basal ganglia. Perhaps you see them a little bit on that slice, but here it's really hard. You don't see a lot of the gray-white matter differentiation either. And so that should kind of be a red flag that you may not be dealing with subarachnoid hemorrhage. Perhaps the problem is not the bright stuff in the sulci. Perhaps the problem is that the brain tissue is too hypodense. And that was the case for this patient who was victim of a cardiac arrest. When the patient went from the CT scan to the MRI scan and underwent diffusion-weighted imaging, you can see that there's very restricted diffusion involving diffusely the brain tissue, mostly the gray matter of the brain tissue. And so that was an example of hypoxic anoxic injury with a pseudo subarachnoid hemorrhage pattern. So also something to keep in mind. So that was the conclusion of our tour of intracranial hemorrhages. So again, the clinical history, the age of the patient, but also the distribution, the appearance, and the pattern of intracranial hemorrhage on the head CT can help you diagnosing what type of hemorrhage you are dealing with, can also help you recommending next steps. And remember the ones that are frequent, like head trauma, arterial hypertension, amyloid angiopathy, all the vascular malformation of the brain, but also remember the least frequent one, like the venous infarct. And remember that sometimes there are mimics like the pseudo subarachnoid pattern. So thank you for your attention. I hope that you enjoyed that review of intracranial hemorrhage, and best wishes to all of you.